So Dr. Ahmed El-Rossassy, Dr. Ahmed El-Rossassy is one of the rising stars in the training of Dr. Mervat. He's very smart, intelligent, and very hardworking. He doesn't sleep at all, at all. He can sleep everywhere, anywhere. He will talk to us about the fundamentals of cryoablation in F.
Okay, thank you, Dr. Sharif. I'm Ahmed El-Rossassy, Assistant Lecturer of Cardiology at Tanta University and a member of Heartbeat Center team for EP services. So cryoablation is getting more and more common as it's simple, has a faster learning curve when it compared to RF ablation. Usually we perform it without 3D mapping, so it has a shorter duration. Also, the balloon design allows for prevention of the backflow of the blood from the pulmonary vein, allowing better and more effective cryo energy delivery. However, it's associated with more flow. And we know that cryo works from the STOP AF trial, the Cryo-AF and early-AF, which showed that cryoablation is superior to antiarrhythmic treatment. And when it was compared with the RF ablation, in the fire and ice, it was non-inferior to the RF ablation with similar safety, except for phrenic nerve injury, which was about 2.7. However, the permanent phrenic nerve damage occurred only in 0.3. So we're going to talk about some clinical points. And first, imaging. Does imaging has a role in patient undergoing AF ablation? We use imaging for two reasons. First, substrate imaging. This is the less common use. The second and more important one is the exclusion of left atrial appendage thrombus. Substrate imaging has some notification in the guidelines. Most importantly, the MRI with lead gadolinium enhancement in the DCAF study, they found that the presence of left atrial fibrosis was associated with more recurrence of atrial fibrillation after AF ablation. They even made a score for it, and they associated with the recurrence, but it needed a high experience, and when they tried to correlate it with the voltage map in the 3D mapping, they found some discrepancies. So MRI is still not common practice, but it is associated with the recurrence. Cardiac CT also has a role. The left atrial epicardial effect is also a predictor of recurrence after AF ablation. Also, some centers prefer to perform CT pulmonary venography to understand the anatomy. Most of cases have typical anatomy of the pulmonary veins, but common trunk and some veins may drain in the roof are also described. So this is maybe helpful, especially when we are not planning to perform the 3D mapping. In the past, they performed post-ablation CT pulmonary venography to identify the pulmonary vein stenosis. However, this is no longer done. But when you have a recurrent case, you may consider to perform CT pulmonary venography to identify the sites of pulmonary vein stenosis and avoid ablating them when you're doing AF ablation. So this is the easy one. The important one is imaging to exclude left atrial appendage thrombus. And when we review the guidelines, we can see that imaging has a class 2A indication in those patients with high risk of increased thrombus, especially if they are not on anticoagulation for the last 3 weeks. However, those who are already on therapeutic anticoagulation and they don't have a high risk for left atrial thrombus, imaging before is an area of uncertainty. This is from the AF ablation position paper in 2023. So we have two categories of patients. Those who are, we categorize them as low-risk patients, and some observational studies suggest that they may be managed without left atrial appendage visualization, but still we don't have randomized controlled trials. And there are those who are high-risk patients, and in those patients we have to inspect inside the left atrial appendage as 1.3 to 2.7% of those who are already on adequate therapeutic anticoagulation still have left atrial appendage thrombus. So who are those that we describe them as high risk? First, those who has a high Schadtz score, those with persistent atrial fibrillation, those with hypertrophic cardiomyopaths. Studies found that those with hypertrophic cardiomyopaths and atrial fibrillation and a Schadtz score of 0 had a higher risk of stroke than those with a Schadtz score of 2 if they don't have hook. So those are risky population. Third of the patient with cardiac amyloidosis and atrial fibrillation, when they performed autopsies, they found that there is a left atrial thrombus. So we can perform a transesophageal echo, and it's the procedure of a choice with 100% sensitivity and 99% specificity. We can also perform a cardiac CT with contrast, and we image in the delayed phase, but still it may produce some false positive results. So it's good sensitive, but the specificity is less than the transesophageal echo. CMR is less sensitive than transesophageal echo and cardiac CT. And intracardiac echo for those who perform ICE routinely may have an option, but you have to inspect the left atrial appendage from the RV inflow or from the pulmonary artery. It's a class 1 to start therapeutic anticoagulation at least 3 weeks before cryoablation. And uninterrupted anticoagulation is now a class 1. Uninterrupted anticoagulation has evidence from the COMPARE trial, which compared those who are on vitamin K antagonist with uninterrupted warfarin versus those who stopped it. And we found that in the uninterrupted group, they had a lower incidence of thromboembolic events, lower minor bleeding, and no increase in the major bleeding. The group who interrupted underwent bridging. Then comes those trials which compared uninterrupted DOACs versus vitamin K antagonists, and they found that they had similar outcomes regarding the protection from the thromboembolism, and the major bleeding was less frequent. And with multiple meta-analysis found that a reduction in the major bleeding about 50 to 55% with the uninterrupted DOAC. So the recommended standard in the guidelines is uninterrupted DOACs before AF ablation. Some small studies recommend flushing the transeptal sheaths before getting in the blood vessels with heparinized flush, about 1,000 units per cc. This is about you flush the sheaths with one ampoule directly. Those patients had less risk of left atrial thrombi when inspected by ICE. However, this was before the era of uninterrupted anticoagulation. Regarding the procedure anticoagulation, we start by giving heparin bolus. The guidelines recommend that we perform it before transeptal puncture, as this reduces the risk of intracardiac thrombi. However, as this is not the practice, of course. Also, intraprocedural monitoring, the ACT should be kept higher than 300 seconds, regardless of whether the patient is already on DOAC or not. Actually, some studies found that those patients who are already on DOAC, the ACT didn't differ, and some studies, as the research studies, found that those who were in the bigger needed even more heparin than the similars. Anticoagulation should be continued for 2 months after AF ablation, according to the regardless of the Schatz-Vask score. Then those who are at high risk of thromboembolism should continue anticoagulation for life. What about antiarrhythmic drugs? Studies say that if the patient failed to maintain sinus rhythm on amiodarone, this doesn't mean he had a worse prognosis when sent for catheter ablation. Also, those who are on antiarrhythmic drugs had a shorter ablation time. However, they had higher long-term recurrence, as the amiodarone tended to mask the non-pulmonary vein triggers. This is a phrenic nerve. We can see that it runs along the side of the SVC, then between the left atrium and the right atrium, then it curves here from the posterior part of the right atrium to the lateral part, crossing across the crista terminalis. So, why damage to the phrenic nerve is more common in cryoablation than RF ablation? This is because of 2 reasons. First, when the balloon stretches, it tends to bring the energy closer to the phrenic nerve. Also, there is part related to the mechanical compression of the balloon exerted on the nerve between the 2 atria. The predictors of phrenic nerve injury are larger diameter of the right pulmonary veins, a flat angle between the right pulmonary vein and the left atrial body, and they found that a larger left atrial is potentially protective. Also, they found that the Polarix balloon tended to had higher instance of phrenic nerve injury than the Arctic front balloon. So how we can monitor the phrenic nerve during the procedure? We have multiple methods. First, the standard one is to base and palpate. We place a decabular catheter in the SVC and we start pacing and we palpate for diaphragmatic contraction, and we stop once we feel that the force of contraction gets weaker. We should take care that there is a phenomena called fatigue phenomena. It means that when we base at high output and for a fast rate, the diaphragmatic contraction may get weaker, not because of the cryo energy applied, but related to the maladaptation of the diaphragm. It's not meant to work at this high rate. The other thing is the compound motor action potential. We connect the ECG in a certain manner that we will demonstrate in the next lecture to record the action potential of the diaphragmatic contraction. And when they come reduced more than 30%, you should stop ablation and wait until they return more than 90% of the baseline. Some of the consoles has what we call it a diaphragmatic motor sensor. They connect a patch to the lower costal margin, and it's connected to the console with a special cable, and it detects the diaphragmatic contraction when we pace, and it stops when we gets below a certain threshold. However, this method had a false positive diagnosis in 52%, so it's no longer used. Finally, the femoral vein pressure waveform. We connect the femoral vein sheath to the hemodynamic, and we record the pressure. If it falls, this suggests a diaphragmatic affection. What about general anesthesia? General anesthesia in AF generally led to shorter fluoroscopic time without increase in the risk. However, with cryoablation, they had similar efficacy and less complication rate. Okay. So, thank you.
Thank you, Dr. Ahmed, for elegant presentation. Now we'll move for Engineer Muhammad Adil from Medtronic.